I'm really excited that Howard, Andrea, and the rest of the PCF team agreed to let us put together this panel discussion. It actually came about from last year's meeting where there was some really novel data that Susan and Dan Spratt and others presented looking at the association between race, ethnicity, and survival within the context of clinical trials. And I think that session created a lot of discussion and debate about whether or not there actually are racial disparities in prostate cancer. I know since that time there's been a really active working group led by Brandon and Dan together that's really fleshed out a lot of the key issues. And so we wanted to come back to you all today. We put together a panel of some really talented individuals, a multidisciplinary team who are working together to address these different points. So we're gonna have a panel discussion. So we're not going to take formal questions. However, if you are in the audience and would like to ask any questions, I don't know if you've downloaded the PCF app. If you go to your app store and download the Prostate Cancer Foundation app, you can chat with me and send a question, and then I can ask it to the panel. So I think we're going to get started. So if you could call up slide number 2, please. I'd like to introduce the panel to all of you. So my name is Lorelei Mucci. I'm a cancer epidemiologist at the Harvard Chan School of Public Health, and I'm going to be moderating the session today. To my left, I have Dan George, who's a medical oncologist from Duke. To his left, we have Susan Halabi, who's also at Duke and is a biostatistician. Then we have Brenda Mahal, who's a radiation oncologist still at the Dana-Farber Brigham and Women's Hospital. We have Elizabeth Platz, who is at Johns Hopkins and is an epidemiologist. Then we're really delighted to have Wes Sholes, who is he's the president of the California Prostate Cancer Coalition. He also is a patient advocate and has served for many years on the US Army integration panel for the prostate cancer research program. And then finally, we have Kosj Yamoah, who is from the Moffitt Cancer Center and is a radiation oncologist. So I think we're going to get started with a really simple question, and I'd like you to answer it yes, no, or it's more complicated than that. And so given where we are today in 2019, would you say there is a disparity that exists among Black men in prostate cancer? So maybe just go down the line, yes, no, or it's complicated.
Yes, and it's complicated, but it's yes.
Yes.
Complicated, yes.
Yeah.
Yes, and it's complicated.
Absolutely, yes.
Yes, and it's complicated.
Right, so I think you can see a general consensus, but maybe it's much more nuanced than that, and I hope this session will really flesh that out. So first, I think it would be a really good starting point to start with some of the epidemiologic terms. What is incidence rates, what are mortality rates, and what is survival? So Elizabeth, I might ask you to kind of talk about those key concepts.
Sure, so this is the didactic section of the panel. Okay. So what is an incidence rate? So with respect to prostate cancer, it's the number of new cases occurring in the population over time. So you start with people who don't have the disease, and eventually people will develop this disease. Those new cases divided by the people at risk, that's the incidence rate. Mortality rate is the same starting population. People at risk, men at risk, people with prostates who are followed over time, and it's the number of deaths from prostate cancer among those at risk. Now, survival case fatality has a different denominator, even though the numerator is the same. So it's the number of deaths from prostate cancer among men who are diagnosed with the disease. It's actually very different than the mortality rate for prostate cancer. So you have to keep that in mind as we go through the discussions about whether or not there's a disparity. Which group is your denominator?
Right, and so just to follow up on that then, are there situations where you could have, for example, a higher mortality rate between Black men and white men, but not a difference in survival? And why might you have those differences?
Yeah, and the answer is yes. Okay, so the survival rate is conditioned on having prostate cancer. If you have a setting in which men are exactly the same with respect to their stage at diagnosis, their grade of disease, let's say on prostatectomy, We could not observe a difference between men who are black and men who are white because we've conditioned so that they are the same. We've made them the same risk of having that poor outcome. Versus in the population, where we're starting with men at risk, there are biological differences in those men. And if they are diagnosed with prostate cancer during that follow-up time, they may receive different treatments, different quality of care. They may have differences in their comorbidities, which could influence the likelihood of them dying of prostate cancer in the future. So the answer is yes, you can have a mortality rate that differs by race, so racial disparity, but not a difference in survival conditioning on the diagnosis in the first place.
Great. I think that's an important distinction in talking about the interpretation of some of these studies. Wes, I want to turn to you right now and get your perspective on, through your work, either on the integration panel or the California Prostate Cancer Coalition, how are the men that you meet who have prostate cancer, what's their perception about the potential for racial disparities in prostate cancer?
Well, as simple as that question is, I too suggest it is somewhat complicated. And the answer you would get to that question will depend upon who the advocate is that you're talking to. And I'll try to articulate that. There are basically, I think, three groups of people that wear the advocacy hat. At the bottom level, if you just envision an equilateral triangle, is where the greatest population would be found. For the most part, those are people who either attend or run support groups. And if you were to walk into one of their meetings, for the most part, it's comprised of people who have been recently diagnosed or have been told that they're terminal. So what they want to hear, what you, whoever you is, the folks who are doing is, what are you doing to address my issue? At the next level up, or the next area, is where I would place myself. People who are more interested in policy and working to modify or to influence policy. A great example of that would be my involvement with the integration panel, okay? And at the next level up, of course, at the highest level, would be the people who maybe lobby Washington, okay? So I would suggest that keep in mind to whom you are presenting that question, because if you were to take one individual from each of those three groups and ask the question, you would get a slightly different answer.
Yeah. So I want to, maybe we can just very quickly kind of go through what is some of the data that we have on this disease. What are the incidence rates of prostate cancer in the United States or globally look like when you compare men of African descent versus white men? I don't know if anybody wants to kind of highlight. We even have some slides we can call up.
So this here is demonstrating the mortality rates by race and ethnicity in the U.S. But incidence is about 102 per 100,000 men for non-black men, and then in black men that number is about 180 per 100,000 men. And then these numbers here that are demonstrated are the mortality rate differences, and that number usually ranges somewhere between 38 and 40 for black men, and non-black men for white men, that's about, the number is about 18. So in terms of the incidence ratio difference, that would be about a 1.6 to 1.8 fold increase incidence, and that hasn't changed even with changing recommendations and PSA screening guidelines. And then the difference in mortality rates is a 2.3 to 2.5 fold increased mortality rate for black men, and that's something that's persisted throughout this time period as well. Even as we've seen, prostate cancer mortality rates go down, that number has always stayed above a twofold increased risk of death for black men. Again, this is a mortality rate that we're talking about.
Right. Oh, yeah.
And despite this, this is a global problem because it's not only existent in the United States. If you go back to the slide before this, I think slide number 4, you see a more of a global picture there, and the hot spots are really in Africa and other parts of the world, and you can see that this is a global problem. When you look at disease in African American men, and you think about men of African origin in the Caribbean and in Africa and different West African countries, and you look at the number of years of separation between the two groups, and yet in the data that we have looking at the West African region, prostate cancer is actually the second leading cause of mortality among men diagnosed with cancer, right? So that tells you that's a problem that exists among the men of African origin that needs to be addressed and needs to be studied, even on an incidence and mortality level. That is actually more of a global problem here, so very important.
Right. So why is it that Black men at the incidence level, at the population level, what do we know or don't know about why the incidence rates are higher?
And the answer is we don't know.
Yeah.
Right? We don't know. So many of us have spent years trying to identify differences in the prevalence of risk factors for prostate cancer that may differ between Black and white men. We look to see if there are differences in the prevalence of genetic factors. So for example, it's well known that there are differences in the number of repeats, CAG repeats, in the androgen receptor gene. So the number of repeats is fewer on average in African American men compared to white men, and there are more in men of Asian background. Does that translate in a difference in risk? Years ago, we estimated maybe it explains maybe about 15% of the difference in the incidence. But so far, we have not come up with the factor or factors that are explanatory. It's not simply a matter of screening, because these differences existed long before we had PSA-based prostate cancer screening.
Right. So Wes?
Yeah, I'd like to just go back to the first question that you asked me, because a lot of us would ask, once you get to the answer to that question as to why, what will you do with the information?
Yeah. Right.
And when?
Right. Right. Exactly. Right. So how much do we think the excess mortality rates that there are in Black men compared to white men is due to the increased incidence? I know, Brandon, you've looked at this. I think others have looked at this as well. I wonder if you could.
Yeah, if we could bring up slide 10, actually. This was a slide that was shown at plenary. And so this was shown by, again, by Dan Spratt last year. And this was a really important study that was published in Yamoah. Also, the first opportunity I got to work with Dan Spratt, and that started a fruitful continued collaboration. But there were 3 cohorts that we examined in the study: the SEER database cohort of men with localized N0, M0 disease, the VA database cohort, and then the RTOG cohort, which included N0, N1, M0 prostate cancer, mostly localized prostate cancer patients. About 20% of the patients were Black, so there were 4,700 white patients, 1,100 Black patients on this study. The curves that you see, the top 2 curves, show differences in all-cause mortality rates, and that was higher in Black men, presumably given higher comorbidity. And then the bottom 2 curves show the PCSM rates, and then the hazard ratio that's listed there is an adjusted hazard ratio. And the hazard ratio actually favored Black race, so Black men did better in the RTOG trial setting. So the overall hazard ratio was 0.81 for Black men. And this was a hugely important study. We had seen some similar data from the VA database showing, limited differences for an individual who's already diagnosed with prostate cancer. But I thought this was amazing to see on an adjusted study with patients who were in the clinical trial setting that Black men were actually doing better. And so I think an important thing is that survival curves don't equal mortality rates. And this is something that Dan and I talk about all the time. So that an individual's risk once they're diagnosed with prostate cancer is captured by those survival curves, but an individual's lifetime risk is captured by the mortality rates. And so if we could advance one more slide, if you do some simple arithmetic and you look at the number of men who are being diagnosed, so the incidence rates, and if you assumed an equal 18% risk of dying from prostate cancer, and you multiplied that by the number of individuals who are being diagnosed with prostate cancer, even though that does account for a good proportion of the mortality differences we're seeing, there's still a 1.8-fold higher increase risk for prostate cancer mortality over Black men's lifetime. So if I could just give you some numbers, about 4,800 to 5,000 Black men die from prostate cancer in the US annually. If you do the math, that means about 2,500 of those deaths are due to disparate deaths, 2,500 every year in the US alone. If you use the math from what we're seeing here and you assumed equal access, equal treatment, equal survival curves, that would actually save about 1,000 men's lives, but that would still leave 1,500 deaths, disparate deaths that are not accounted for. So I think this is a hugely critical study that shows us something we can do, and that if we implement it successfully would save 1,000 black men's lives every year in the US, but we would still have to help save those 1,500 due to disparity alone, and we don't know what exactly may be driving that.
I think there's a couple of really important things that are you have to be careful with this slide, and one is that that bottom curve is this is the RTOG randomized controlled trial setting. So now we're talking about patients as part of clinical trials, and there is a huge selection that goes into the patients that are participating in clinical trials. I mean, there's a selection of the patients themselves willing to go to centers where they have clinical trials and participate. There the eligibility criteria that they have to meet. There's the the resources it takes to participate in clinical trials in terms of the number of visits and follow-up, et cetera, to understand and read the consent forms and all of those factors. And so I think this is really wonderful to see that when you control for all those factors, as Elizabeth said, when you start controlling for all these things, we really see kind of these curves come together. And in fact, I think one of the really fascinating things here is actually they do better. And we're going to see this. Remember that hazard ratio of 0.8. You're going to see that come up over and over again. And that may not be, that may be borderline statistically significant when you look at one study. But when you see that same trend over and over again in different disease states, in different treatments, in different settings, it becomes more and more believable that what we're seeing here is a biologic difference in terms of treatment outcome associated with this. So I think that's really, really important to see that those curves are not overlapping there, that the African American black patients actually do better. But it's also important to recognize that it's a very, very selected group of patients that we're dealing with there. And the other, I think, interesting, important piece that's left out of this population are the patients who present with metastatic disease at diagnosis.
Right.
That's only maybe 5 or 6% of our population, these so-called metastatic hormone-sensitive prostate cancer patients. But if you look at mortality, that's 100% of the patients that die within the first 5 years. There's essentially no patients that are dying in the first 5 years who are presenting with localized disease. Right. So that population is really the early drivers of death, and that's really what we're concerned about here.
I wonder if also someone might comment, the other part of this curve I think I just am appreciating now, you look at how much higher the cumulative risk of dying of any cause, and you're seeing the success risk. So I wonder if someone in the panel might want to comment on that observation and what that means, and I guess more so about the so what can we do now with this kind of data? What does it mean when a man with localized prostate cancer is African American presenting? What should we be doing about the other cause mortality? I wonder if somebody else on the panel might want to comment on that.
I can take this one. I mean, this is not surprising, and the same trend is demonstrated in men with advanced prostate cancer. So basically, what you're seeing here, Lorelei, is that most of these men are dying of other causes and not prostate cancer. So the key question here is why? Is it due to comorbidity? Is it due to other things? And in this analysis, Brandon said it was an adjusted analysis, correct? So you adjusted for stage, you adjusted
for the hazard ratio.
For the hazard ratio.
Well, I can tell you why.
Okay, please
because
go
they're
ahead.
old. So when you look here at the patients who we treat with radiation therapy for localized disease versus those that go for surgery, the patients who get radiation therapy tend to be older. And if you're, say, age 70 at year 0, when you get to year 20, you're 90. So most of those patients will have died. It's just that they're not dying of prostate cancer because the radiation's working.
Right, but you're also seeing this excess, though, of mortality overall. So maybe one thing to kind of push back on is a little bit, maybe thinking more holistically about patient, and you not only are trying to reduce death from prostate cancer, but improving overall survival.
Right.
And so thinking about that disparity as well.
Well, that's the whole survivorship piece,
Yeah,
right?
right.
And I think we need to think of that in terms of disparity, because there may be other issues at play, other comorbidities, et cetera. We can't have a survivorship program that's one size fits all.
Right.
Yeah, that's true. I mean, to take this further, we've done an analysis in men with metastatic castrate-resistant prostate cancer. And in this analysis, we had men over 8,000 from 9 clinical trials. Now, this is worldwide. I think there were only 3 trials that were from the National Cancer Clinical Trial Network. And the surprising thing is, again, we found the same pattern like Brandon and Dan's Platz analysis. The hazard ratio was 0.81 when we adjusted for known prognostic factors. But again, I would like to underscore that this is a highly selective patient population. Those patients were eligible to enroll, and they don't represent the general population.
And then to add to that, so this is an important construct for all of us to really wrap our mind around. I think towards the end, I'll show you some slides to demonstrate that. You're looking at a study where the endpoint is really response to a specific treatment. So everything we've talked about so far, be it the RTOG studies or docetaxel or even Provenge, you're looking at response to treatment in an identical group of patients, a biologically identical group of patients. You would expect that, given what we know, the response to treatment would be identical. And I think for us to frame our construct of when you say you're looking at disparities, what are you actually looking at? What endpoint are you looking at? It's going to be important to know what your endpoint, your results is going to be. And this really frames the discussion for us to recognize when we do research, when you take patients and you adjust for biology and make them basically biologically identical, and then you test for response to treatment, most of the time you're actually asking a different question. And in the RTOG studies and in the immunotherapy studies, we are seeing that perhaps there might be a biological advantage with some of those treatment regimen for African-American men. That's awesome. That's actually a progress in the field, that for the first time we can actually begin to understand some of these underpinnings that can help us harness the biology and really treat our patients appropriately. But it's important to recognize that that means that more patients on these studies for us to understand that. That means that more reaching out for us to really get samples also sequenced. And these are things that we cannot neglect because we are just at the precipice of really understanding what's going on. So I think these are very, very important studies, and the results are going to inform us.
Right, so let's, can Wes go first, and then you?
Oh, yeah.
Yeah,
course,
please,
course,
yeah.
Just to throw another weed in the weed patch here. My assumption is that most of you in the room, if not all of you, will engage in your work, for the most part, at a university-based hospital, okay? Or university-affiliated hospital. And I think by doing so, obviously, you are getting access, and you're using a portion of a much broader population. And in some of the other forums that I participate in, I often ask the question, well, of course, your product would be of great use to research-oriented facilities, but what about the patients of Dr. Jones, who's a solo practitioner in his office on 6th and Main? Right. To what extent will those patients have access to participation in a clinical trial? I have absolutely no solution for that, but I think that is another factor that should be considered as we go down this road.
Yeah, I want to let Dan talk, but then I want to go back to that comment, Wes, because I think that is something really important to this topic. So Dan, did you wanted to?
Yeah, on the bottom here, we have the number at risk for white and black. And Susan, this was an amazing effort, but you have like, what is it, 7%? 6% of the patients were black. I mean, you took 9 phase 3 trials to be able to show this treatment effect. And
exactly.
You shouldn't need 9 phase 3 trials to see this kind of biology, right? I mean, we should be able to see it with one trial.
I absolutely agree. And sadly, I've done this same analysis like 15 years ago using data from phase 2 and phase 3 clinical trials conducted by CALGB at the time. But at the time, we had only 110 patients. And the data were coming from different trials with different treatments. Some of them were phase 2, some of them were phase 3. So then I said, let's look at a group of patients all coming from phase 3 trial. They were all treated with docetaxel versus docetaxel, which is the standard of care, and an experimental arm. And still, like 15 or 20 years later, we're finding the same trend. But what was shocking to me, and we don't have a slide on that, is that among the 5 adult cooperative groups in the United States, looking at over 26,000 patients, only 6% of those patients were African-American men.
So actually, if you pull up to slide 21, it's relevant to this. This is a slide looking at all phase 3 or 4 clinical trials, prevention, screening, or treatment trials. And sort of Dan's been a part of this project. So it goes to your point, though, of just the proportion of, and these were actually the trials that reported race ethnicity. There were actually a whole bunch of studies that didn't report it and weren't required to report it. And when you ask the authors about this, most of them said, well, I didn't report it because they were all white men. So actually it's even worse than this. So,
Right.
Yeah, I mean, and just to put it into context, right, 14% of the population in the US is Black. Yeah. And we're saying there's a 1.6 times greater incidence of this disease. So now you're probably looking at 22% of the population. And here, it's down in the single digits, less than 5. Yeah. It's a huge underrepresentation. It's to Wes's point. I mean, we're not opening trials where these patients are accessing care, and access. That's really, to us, I think, a big issue with access. I mean, there's healthcare access, but clinical trial access, I think you've seen now through a number of these studies, there is a disparity in favor of African Americans potentially having a better outcome, and we're not giving that to them. We're not offering that nearly enough.
Right. Yeah. So I think a mandate for all of us is really, as we continue to develop studies and think of clinical trials, collaborative work across the spectrum at our institutions, to really begin to consider how we design these studies, where we design them, where we open them, because we can be part of owning this problem and bringing solutions to it. I think it's great to look to policy to change some of that, but I think we are the scientists in the room, and we design these trials and talk to our friends to enroll patients on that. And if we can think about how we even design our eligibility criteria, which affiliates we involve, I think this can actually change some of these numbers in the next decade. So we are appealing to all of you to get involved in this way.
Right. So Wes has, throughout this, us all meeting and talking about this panel, one of the things he keeps telling us is what is the so what of this panel? And I hope one thing that you'll hear loud and clear is that as a community, and all of you sitting here, we need to do a much better job than we're doing in greater diversity in trials. So I guess just kind of following up on this point quickly, and then I want to switch a little bit. I wonder, Elizabeth, if you can share, I know you've talked and thought a lot about how cancer centers, the CCSG grants, might play a role in this. And then, Wes, I'd love to hear your thoughts on ways in which we need better partnerships between people doing clinical trials and patient advocate groups. So I wonder if you can just comment on that.
So cancer centers, as part of their Cancer Center Support Grant funding, are required to define their catchment areas and then to ensure that research is being conducted to address the problems in those catchment areas. And so what we need to do, and this involves everyone, it's not just population scientists, is to figure out where is the burden, right? Look across your catchment area, figure out where the rates of prostate cancer are high, where the mortality rates are high. Look by neighborhood. We heard a talk this morning from Mindy, or this afternoon, early afternoon, where she looked at neighborhoods and figured out archetypes. So we need to look, we need to figure out where the rates are high, and then we have to make sure that we are truly doing research, including trials, to recruit individuals from those settings. So not just say, I'm studying prostate cancer, we have a problem with prostate cancer in our catchment area. That's not enough, right? So just to say, I study prostate cancer, we have to make sure that we have the right trials in the right place, the right prevention studies in the right place, the right screening studies in the right place. So cancer centers do play a very large role in ensuring, through requirements, through the peer review process and the funding process, that we take that charge very seriously.
Yeah.
And to add to that point, actually, it's, Elizabeth, I mean, this is a great point. In addition to that, I think also the networks, the cooperative groups, need to make a concerted effort to recruit underrepresented population, whether it's African American or Asian or Native
Or
American.
rural, right?
Right,
Or
exactly.
rural or socioeconomically
exactly.
disadvantaged,
Yeah, right.
absolutely.
Elderly, when you look at data, some of the big analysis done by the SWOG group have shown that there is really a big problem here in terms of enrollment. Yeah. So if at the national level there is sort of a mandate, like you need to make more efforts, whatever resources needed to be put in place, I think this is maybe a plea we need to make to the leadership at the highest level.
Yes, indeed.
Yeah. So Wes, I wonder what your thoughts are on ways, are the researchers and clinicians here reaching out and engaging organizations like the California Prostate Cancer Coalition? And if not, what should we be doing to kind of enhance diversity in trials?
Well, I will publish an article if I knew the answer to that one. I'm not exactly sure. And I am not starting off with the assumption that they're not doing anything. So I can only assume that their actions is limited to the scope of their knowledge.
Yeah.
So I would be interested if I could do it, if it was possible to do it. There were two presentations made today that I think were very interesting, and I wonder to what extent it was new data, particularly for the younger people. The discussion on neighborhood, the discussion on exercise, and it is more likely they would be familiar with those concepts on the neighborhood. So what is your possible takeaway from that? If you are a practicing physician, maybe even a physician scientist, did you ever consider factors like the background, the neighborhood of the person that you're treating? If not, hopefully you got some information today that could add from that. And another factor is, do not assume that the so-called black community is homogeneous, because obviously, it isn't. Because, the last 100 black men, for example, that I've interacted with, say in the last week, most of them are personal friends, my fraternity brothers. Probably 90% of them are college educated, at least at the BS level. So of course, I don't have to talk a lot to those people about what we're talking about. So know your product.
Yeah.
I think that's a great point. I mean, if you go back to that slide that Kosj put up, number 4, just looking at Africa, I mean, the north versus the south of Africa is a huge difference in the mortality of prostate cancer.
Right.
And so, I mean, I don't think you can just assume that even African ancestry is homogeneous.
Right.
No,
I mean, I think that's tremendous diversity there.
And then that's actually an important point you bring up, because when we looked at, I think there's a slide 32 or so, not sure. When we look at, we have a recent data coming out from the Native African cohort in Ghana. So if you look at on the left-hand side, this is looking at patients in the United States and Africa all had genomic work done in the same platform, and the ERG mutations came out as you'd expect. On the other side, on the left side of the blue line is really ERG negative, and you have ERG positivity, and that's kind of what you see in the 50-50. When you stratify them by size, so the first top panel is European American patients. You see that percentage we all quote in every panel or in every ERG story. It's about 50-50. When you look at African American men, that percentage drops a little bit, And when you look in the native African men from the West African region, it's actually even less. So it looks like even for the biology of this disease could be different in the sense of majority of these patients, 90% plus, are actually ERG negative. So the ERG story does not apply to 90% of men of African ancestry. And if you go to the next slide after this one, we actually show you that when you look at it, when you stratify this by centrally reviewed Gleason grading, and even group grades 1 and 2, the disparity is still there. Gleason groups 3 and above is still there. So it's not a question of high Gleasons versus low Gleasons. This has all been centrally reviewed. The biology is just different. And it's important for us to understand how that plays a role in affecting endpoints when you look at the disease itself.
Kosj, what can you remind us what is EAM, AAM, and NAM?
Right, so European American man is the EAM, AAM is African American men, and then Native African men are patients diagnosed with prostate cancer in Africa whose slides have been reviewed centrally in the United States and who have had genomic work done on their samples.
Okay, perfect. So I actually have our first question from the audience that I'd like to ask the panel. What measures can be taken to provide access, awareness, and eligibility for African Americans, whether, sorry, I don't have my glasses, within the nation or Africans globally to be enrolled in clinical trials? I'm gonna start with Dan, because I know we've talked about this in the context of a project we're involved in, and I know you've thought about it a lot, but I'd like to open it up to the panel as well.
Yeah, you know, I think this is one that I think we can all share in, because I think a lot of this is really, you know, we could act locally, and I think that's important. Wes, you talked to us about that earlier, you know, acting within the communities we work with, the referring centers we work with, whether it's in our catchment area or across our state. But I think we can also have a voice as a community and really building up why this is so important and why it's so important to do this prospectively. These retrospective analyses are great for forming hypotheses and corroborating patterns of care. But we really need prospective analyses if we really want to get at the biologic question of why there are disparities associated with this. And what you showed there is just one glimpse of the biologic differences that we can see. So I think, you know, having a voice on that. One way that we're doing that is with this large registry project we're involved in called Iron Man, which is a prospective, you know, international, but certainly US focused as well, registry of patients with advanced prostate cancer, metastatic hormone-sensitive disease, castrate-resistant disease, getting them involved in this project. And you might ask, well, what's in it for the patient? And what we do, essentially, this becomes a platform. It's a platform for them to interact with the research staff to hear more about trials. About 40% of the patients that are involved in Ironman at our center are also co-registered on clinical trials. So it's a great opportunity. You need that? It's a great opportunity to really connect with these patients more than we do in a busy clinic day if they're not part of a structure like that. It's just one example. We're going to learn a lot from that prospective collection of blood samples and other things, but I think there's also a great way to introduce clinical trials to patients that's really not risky to them.
Mm-hmm. Anybody else?
If I could add something slightly provocative, we need to do all of those things, and I think we also need a culture shift. With disparity study, with different studies that come out, we say, okay, it's your fault, it's bio, it's access, it's policy, it's social scientists, it's all of our problem.
Right.
And until we make it all of our problem, it's going to continue to be a national, a global problem. And I think as you're in the lab doing the basic of basic science, think about this problem. Mm-hmm. As you're doing clinical trials, think about this problem. That's how we're going to do this. If everybody's thinking about this problem, these initiatives will be easy.
Yeah.
So it's a culture shift, and that's my challenge to you. This is something that we have to own. It's on us.
It's a call to arms.
Right.
Yeah, right, exactly. So Wes, and then.
Could I just like to elaborate on that concept? It is a multi-part issue. So there's very little you can do about poverty rates in Southeast Los Angeles and the neighborhood, but there may be something else you can do. So focus on that small piece of the problem that you have influence and control over. It's just like you cannot solve the issue of poverty in the US. But there are certain aspects of poverty poverty, you may be able to attack on a personal basis.
Right, right.
You know, we tried to do this. You know, at Duke about 5 years ago, we started a study with a parallel group study of African Americans and white patients getting the same exact treatment, you know, chemo-naive, castrate-resistant prostate cancer, standard of care abiraterone, free drug. And I wrote this trial, it's IST, and it was shortly after Cougar 302. And we wrote this trial for our cancer network, right? Just as Elizabeth said, you know, we got to bring it out there, we'll put it in the network, we will, you know, put this trial, and I thought this free drug, this should accrue like easy, right? 7 accruals in 1 year. And that included our site at Duke. And that includes, you know, white and black. So, you know, we wrote it for 100 patients. It was going to take us 13 years to get that trial done. Thankfully, the sponsor, Janssen, was stuck with us, gave us some additional money to go out, and I recruited some of you all, some of our friends at Carmanos and Tulane, and UAB, and some VAs. And over the next year and a half, we got that study done. But we didn't get it done in the community.
Yeah.
We got it done in academic centers and VAs. And I think a couple of lessons I learned from that. Number one, you absolutely have to go where the patients are, but you need clinician leaders.
Yeah.
You know, that these community places, the physicians there were not engaged. It wasn't their work, it wasn't their question. And when I went to the people who are prostate cancer leaders, we got it done.
Right.
Number two, you need clinical research infrastructure. You can't just put it in a place where there's one nurse that comes in once a week. I mean, it has to be in a place where they do research. And they're going to take the time to talk to patients. And number three, you have to change the criteria. We amended that study 26 times because of all the eligibility issues we ran up against, from windows to you know, levels of, you know, hemoglobin or you know, blood glucose or what have you. We started with the Cougar 302 eligibility, and we picked away until we had something very, very different from that.
And I actually like that point, because the mistake we make in our clinical trials is that we make it so restrictive that it only works for a certain group of patients that fit a certain box. But that's not the real world. And I think that amendment shows what actually happens. And if you're going to change that, we have to sometimes develop real world studies that will actually answer the question.
Yeah.
So thanks for bringing that up.
Right. So I think we're going to switch now to the topic of biology. And actually, I'm going to lead off with a question from the audience. If the hazard ratios, once patients get to treatment, are similar, if not better, is the biology underpinning the disparity then driven by incidence and stage at diagnosis? So that is the first question. So I'm going to put it out to all of you. And I know we have some slides about that you might want to bring up. So is it or isn't it? Maybe we can start with a yes, no, it's complicated.
It's complicated.
It's complicated.
Yeah.
I mean, I think you could say a good proportion may be due to that, but it's more than that. But certainly, that's an area of focus. That disparities start early. Yep.
Yeah. I'd say in part, yes. And then we also still have to think about men who were not eligible for trials,
right.
Because they're still not being counted in that survivorship.
Yeah.
I would answer that with a question. Assuming the answer is yes, and assuming the answer is no, what would you do under either circumstance?
Mm-hmm. That's a good
what
question.
Would you do with that answer?
With that information, that's a good question, or good response,
And my response to that is both. So, which is obviously is complicated, because we look at race as basically as a social construct, and I think there's been a lot of debate in the epidemiologic field about what race is, and this would be a nice segue for us to really begin to understand when we say biology versus access or quality of care, what do we really mean? I think both contribute to the problem, but even like Brandon has spoken about it, when you adjust for all that, you still see the excess mortality, and what is that attributed to? Is it biology, and if so, by how much? The question is, what are you looking at? What is your readout? What is your endpoint? And so we can go to slide 34, which really, I think, sums up a lot of what we've been talking about to this point, slide 34. Okay, so let's go to the next one. So when you look at the whole problem of prostate cancer disparities, right, I want us to focus a little bit. This will take us some going through the charts and then coming back to it. So when you look at biology versus access, you have to ask yourself this question: are you talking about incidence, incidence rates, are you talking about adverse clinical presentation? Are you talking about suboptimal treatment delivery? Or are you referring to treatment response? Because all these things contribute to lethal outcomes and mortality. And depending on your study or depending on how you design your work, you get a different answer. And this is why our literature is so bogged down with so many conflicting studies, because we are not identifying what we are trying to answer. Which part of this series are we actually addressing? So one study says there's no difference, and they are talking about treatment response. One study looks at incidence, says there's excess outcomes. So this is a very important framework. So let's break it down. So when you look at genomic profile, when you look at a genomic profile of African ancestry, right, that's the genetic makeup, okay, and that would impact the person's race. So that race is an identifier, which is a social construct, and that brings together with it a whole lot of things that we need to break down. So as a scientific community, when someone says I'm self-identified as Black, what does that mean, right? Now, we know that a bunch of studies now looking for us to go back and do genomic and genetic ancestry to figure out exactly what that proportion of African ancestry really means and if that contributes to the outcome. But let me walk you through real quick. So look at prostate cancer incidence as your outcome of interest. So genomic profiling will impact, obviously will make you a Black person. That doesn't change, right? But that might negatively impact your access to care or the quality of care you received, right? So that becomes a social problem. That's a socioeconomic issue, right? And that remains the same across the board. But increased access and quality of care actually would augment PSA screening because your prostate cancer gets diagnosed. So as a collective result, you get a negative impact of Black race on prostate cancer incidence. But the data is saying the opposite, that the incidence is higher. So in fact, I would argue that the incidence actually artificially suppressed. The 1.64 we talk about is probably a lot higher than we see because the Black race actually being negatively impacted into how much we are picking these cancers. So a lot of that incidence will be driven by the biology rather than access to care, because you can argue access to care should actually diminish the incidence rates, that the observed incidence rate, let me put it that way, right? Then you go on to the next one. So we're looking at our adverse presentation, because these are separate questions that we as scientists have to frame our mind as to what are we looking at. In adverse presentation, you have the same interaction between genomic profiling and Black race, which impacts access to care. However, if you have increased access, you do not have delayed diagnosis, and you actually have less adverse clinical presentation. So Black race, because of the social contrast, might actually experience adverse clinical presentations as a result of that. So therefore, you have two contributing factors, access to care and biology, which is an emerging field of each year's biology, tumor location, all that, coming to perhaps play a role in the adverse presentation, but maybe more so driven by access. The third one will be suboptimal care, which is solely an access issue, right? Because there's no biological input to why a patient should get suboptimal treatment delivery. So that's solely driven by access. And when you go to the last two on the next slide, please, then you talk about treatment response, and there's emerging data that we've shown in the RTOG studies and the PROVENGE and others that perhaps there might be a window where treatment response might actually favor Black men, depending on what you give them. But for the most part, that's something that could be modulated mainly by access to care if they are not given the actual delivery they need. And then finally, all these will impact lethal outcomes. So now let's go back to 2 slides before that, where I had a table put together, yes. So when we frame, I think this is a framework that we all need to start thinking about the problem, right? That what question are we trying to address? If it's an incidence question, if you look across the board, biology would increase the incidence rate. Perhaps through emerging data, increase adverse clinical presentation, but have no impact on suboptimal treatment delivery or treatment response. But that cumulative additive impact becomes a major contributor to the poor outcomes. And when you look at access and quality of care delivery, it has really no role in incidence rates. In fact, if anything, it works against the observed incidence rates. But it definitely affects late diagnosis and late presentation, and invariably affects suboptimal treatment delivery from a lot of the data we have out there. And cumulatively will become a mediator of lethal outcomes and mortality rate. And when you add this all up, you begin to make sense of what's going on in disparities, where you have increased PSA, increased stage, increased lesions or diagnosis, but this is a cumulative problem. So when you start to sort it out, you start to adjust for these things. You're adjusting for a whole lot of things, but it's not perfect. And obviously, we know suboptimal treatment and delivery could be eliminated by equal access, but even with that, you do not eliminate the entire problem. You still have the excess mortality that Brandon Mahal showed. And I think all of us really have to think about it when we design studies, or when we're talking about we are evaluating a disparities paper, or reviewing it, or designing the study. where in this framework what are we trying to address? And I think that's going to be very important for us to really take home when we begin to address this issue on a more, as a scientific community. So I wanted to bring that up in that discussion so we can really engage more.
There's some really great questions coming in. I know some of them are coming in through a different mechanism. I think Ruth's going to try to send some to me. But I actually want to change the topic a little bit because I think someone's raised a really interesting question. It goes to this idea we need to keep our eyes not only what we know is a disparity, but where might there be a disparity going. So the question relates to the study about there's a great discussion about African-American gentlemen. What about Hispanic gentlemen? Thoughts? It's a heterogeneous group, and it's an important topic. There's comments on Southern California, but I think across the US this is something, and I know there's some evidence suggesting, well, I would love to hear your thoughts. Is there an increased burden of prostate cancer in certain groups of Latino men? And if so, what are we going to do about it? And so I'd love to open that up and hear comments.
Yeah, there's data to show that men with West African ancestry, even who are Latino, who identify as Latino in terms of ethnicity, have an increased incidence of disease, increased incidence of aggressive disease, higher mortality rates. Now, again, the question is really important because it's getting at a lot of admixture and different genetic ancestry. And so in the Latino population, there's a significant heterogeneity there. And so you see that actually men with more European ancestry tend to have outcomes that are similar to what we would, patients who are self-identified as white in a lot of the SEER estimates. Yeah.
But I think the point is that even if the rates are similar, the biology may be different.
Right.
I mean, that's not to say that there isn't factors associated with those germline genetics that aren't influencing this. And it's, we're never going to get at those questions if we continue to have our CTGA made up of 95% European ancestry, if we continue to use all the tumor models that are all, Caucasian-based tumors, and we continue to put 95% of the patients on study who are white. Yeah. I mean, we're just never going to answer those questions. So, I mean, I think to me, it's the answer is we don't know because we're not looking.
Right. And I think you bring an important point. I think that's the reason why we look at whether it's Hispanic or it's African American or African ancestry as a surrogate for biology. I don't think any of us in this room should have an African American patient come into your clinic and say, well, I'm going to give you this because I think you're African, you're black. No, I think that it behooves us to understand the biology so we can use personalized treatments for patients based on the underlying biology. And studying race is just a surrogate for the biology. I often use this analogy that the BRCA mutations was first identified in Ashkenazi Jewish population, right? Then we identified that in triple-negative breast cancer African-American women. And now we have PARP inhibitors that work better for the patients and so on and so forth. And now we can target all men and all patients of all races if they have that mutation. But if you don't look, you won't find it. If you don't look in that population that enriches for that biology, you will not find it.
Right, we need to be really having a diverse population. So there's some really fantastic questions coming in, and I want to put this out. I think, Elizabeth, you might be in a good position, but really anybody to think about, and this gets at this topic of incidence and what do we know about vitamin D? I know the results of the VITAL trial came out, which were kind of interesting. So the question is specifically about the impact of dark skin, living in high latitudes and vitamin D conversion. What do you think about that? Is the evidence sufficient? Do we need more data? What are your thoughts about vitamin D?
So it's very well recognized that individuals who have darker skin have lower circulating levels of 25 vitamin D, which is the sort of nutritional biomarker of vitamin D. What's not distinctly different is 125 vitamin D, which is the hormone that's actually the functional version of vitamin D. So it's, if you think about those kinds of differences among populations, and this is not race, this is skin color, right? So melanin. So, does that translate into differences in risk of prostate cancer or the aggressiveness? It's not that clear, right? So even though they're profound differences, they're differences even if you look in the in utero environment and you look by race and you look in cord blood levels, there are differences in vitamin D level based on skin color. So I'm not convinced that we have an answer to that question. We need to probably know lifelong vitamin D levels, where people have lived relative to sun, relative to their dietary intake. I don't have an answer to that question.
Right.
We thought years ago that maybe there was a clear association. I don't think it's as clear right now.
Okay, yep. So I think this is a really important question, and I'd like to ask Dan and Brandon about this. Should we be screening and or treating Black men differently than white men to narrow the mortality disparity? Let's talk about that in the context of everything from radiation to more advanced disease, but also active surveillance. So what do you guys think about that?
Yeah, I think it's really interesting. I think, there are some subtleties that I do take into consideration. When I have a African-American patient who has multiple cores of Gleason 6 cancer, we've done a study, we've been collecting tumors on these patients for years now. We've been finding, 80% of those are upgraded. I mean, there's a very high likelihood when it's high volume that you're operating, that there's higher grade disease there. So, that may be, a context. We're finding on MR in screening patients that there are differences in MR by race. So I do think that, racial differences factor into how I think about how I'm going to follow patients in some of those circumstances. When we see some of the effects that we see with hormonal therapies or chemotherapies, it brings to light that hormone-sensitive metastatic disease setting. It's not that I treat them differently, it's just that I'm more encouraged to treat them.
Yeah.
I'm more inclined to say, this is therapy that could help. So, would love to have prospective data that shows that, but short of that, I'm using information like that to help convince people that these therapies we have, even though they weren't tested in their racial group, can still be beneficial.
Right.
Yeah, and I would echo what Dan said, especially about, in terms of treating individuals differently. I don't, at this point, think there's, enough evidence to suggest we should treat men with localized disease differently. I think Black men should still be offered active surveillance and look for more trials like you're doing. I think the screening question is interesting, though, because correct me if I'm wrong, the epidemiologist, but if a disease has a higher burden, if there's a greater burden of disease in a certain population, that screening tool should be more efficacious in that setting. We need data to show us how much more that might help, but I think, right now we have an initiative going on in Massachusetts where it's a risk stratified screening tool that we're trying to come to consensus on and test that in Massachusetts. So.
Right.
I think some of those answers will come out.
Right, but it's pretty disappointing that we did that. I think the PLCO trial tried to enroll sufficient Black men, but just didn't make it. So we don't have that answer. Yeah. So we have, unfortunately, just 2 minutes. I think Ruth, unfortunately, it went to close, so I wasn't able to look at all the questions. But we also just have 2 minutes left. So I think we want to wrap up. I want to give everybody their short, to Wes's point, so what? What do you want this group of people to leave with as kind of the next step? Where should we be going? So we'll start with you, Dan, and we'll go to the end. Yep.
14% of the population is African American. They have 2.2 times the rate of prostate cancer death. That's 30% prostate cancer deaths. A third of men that are going to die in this country are African American. If we're not interested in including them in the research that we're doing, whether it's from the tissue to the trials and the drugs, then we're ignoring a third of our population. And I think we just can't afford to do that. And we can learn from this. I mean, that genetic diversity is going to help us. The first question we started with was, why do they have a higher incidence? And biologically, we don't know. Yeah. We have to understand that. Yeah. We have to start at the beginning with these patients from screening, and we have to have them engaged in our infrastructure, however it takes.
Okay, Susan?
I think it is a very important question, and I think this is an area that deserves more research. Obviously, the biology question is an important one. I think collectively, we need to identify what the barriers are and have a multi-pronged approach to enroll African American men, and not only African American men, but other underrepresented patients in the trials.
Yeah.
And I'd like to just say again that this is our problem. If we eliminated prostate cancer disparities today, we would save the lives of 2,500 black men in the US annually. So let's do that.
I'm a public health person. I believe in prevention. We don't know how to prevent this cancer, and we don't know how to decrease the disparity based on incidence. So while we continue to search for those factors, especially those that we can intervene on, we need to recognize that trials are the great equalizer. So if you get into a trial, the quality of your care is higher. It doesn't matter who you are. So we need to make sure that we enroll black men in trials, not just so that we have the answer for whether the therapy works in every racial and ethnic group, but because the care is just better, the outcomes are better, overall survival's better.
My interest is mostly policy, and I'm extremely pleased as I look back over the last 12 to 15 years I've been engaged in this type of dialogue, that there is a genuine interest being expressed on this open question relative to population science.
Now, I want to end by saying that in the era of personalized medicine, we want to make sure that we actively include so many African American and African patients that have prostate cancer, because if we don't do that, guess what? The disparity will just widen even in this generation. We don't want that to happen. Yeah. So let's get to work there.
Great. So I'd like to just finally say I can't thank this amazing panel enough for your insights and for your hard work on this topic. I'd like to also invite everybody to be a part of Brandon and Dan Spratt's monthly or so working group addressing disparity. They really go into depth on specific topics. I want to thank Andrea and Howard and all of PCF for allowing us to have this session, and I think we'll just wrap it up there. And thank you so much.
Great.
Thanks
Okay.
for that.
Great job.